Welcome, everybody. My name is Julian Chun, and I am working in Frankfurt, in Germany, and I have the privilege and honor to chair this very exciting session. We have two operators or a combined team, a heart team, already ready, prepped up in the OR. We have Dr. John Yap, who is a consultant cardiac surgeon at Barts Heart Centre and co-founder of London Heart Specialist, Harley Street Clinic, and he is one of the lead surgeon for the major aortic program and a specialist for arrhythmias, of course. And then on board as well in the OR, we have Dr. Syed Ahsan. He is a consultant cardiologist from the Barts Heart Centre as well. He is a highly experienced operator for simple and also complex catheter procedures, and they will work as a team. And here in our virtual studio, we also will work as a team, and I'm very happy to welcome number one, Professor Carlo de Asmundis from Brussels. He is chair of the Heart Rhythm Management Center at the University of Brussels and director of the postgrad program in cardiac electrophysiology. Welcome. And we have also on board Professor Richard Schilling, who is the course director of this fantastic Rio meeting. And Richard, welcome as well. I don't have to introduce you anymore, of course. And also a warm welcome to Professor Peter Spector. He is a professor of medicine and electrical and biomedical engineering at the University of Vermont. And we are ready to go over live to the OR, where we will have to see our colleagues and presenting the case. And I am really excited to see what's going on in this very special scenario.
Good evening, everyone. Thanks for joining us here at Barts Heart Centre. My name's Syed, this is Mr. Yap, and we're really happy and excited to be doing our live case here today. So this is the AF Heart team, and I'll hand over to Mr. Yap, consultant surgeon, to introduce everyone.
Hi, everyone. We've got a fantastic team here today, our regular team. We've got probably a few more than usual, but that's always helpful. To start with, on my left is our anesthetist who I've worked with for many years, Ann Campbell, and Rose is our ODA. And we've got Mo, who is our radiographer. And my esteemed colleague, Mr. Kovakar, Sham Kovakar, who started the program with me back in 2014, when we were the first early people to adopt it. And I've got my fellow here, Katie from Ireland. And we've got Crystal, who's really been instrumental in bringing this program forward. And got Rena, Emily as well, and James. So we're all ready to go. And I think Syed is going to talk a bit about the patient. Just as a background, I've already made the incision, which we will show you. And we've already placed the position of the esophageal probe, which we can talk about why is it important for us. And then we will go ahead. We will go through all that. I'll give it to you, Syed.
Thanks, John. Okay, so this is the first part of the Convergent hybrid procedure, and we'll talk a bit more about that later on during the case. So this is the surgical component, and this patient is a 76-year-old retired dermatologist from Scotland. So she's come to London to have this procedure performed. She's had long-standing persistent AF for over 2 years, and she's extremely symptomatic in AF in the HRA class 3. Her echo shows preserved left ventricular ejection fraction. She's a small-framed lady. She's only about 65 kilos, but has a severely dilated left atrium on echocardiogram with a volume of 103 mils. She's had a couple of attempts at previous catheter ablation, one in 2019 following a failed DC cardioversion, following which she was only in sinus for a few weeks but felt dramatically better. And then again earlier this year, again, only remaining in sinus for a few weeks. She's been intolerant of medications, beta blockers and amiodarone, and prior to 2018, she was very fit and active, walking her dog and really unlimited. So AF has really knocked her. So just before we go back into theatre, I just wanted to show you a brief animation. So the surgery starts with a small subxiphoid incision, which is normally between 1 and 2 inches. This allows access for the EpiSense surgical ablation catheter, which John will demonstrate to you, which goes onto the posterior wall of the left atrium and is able to deliver epicardial lesions. So it's about 3 centimeters long, and each ablation, as you'll see, lasts for about 90 seconds. The key things here are the safety, which John will talk again more about, but we've done a TOE beforehand, which shows the appendage is clear. She's had a CT, which shows no thrombus. So once the procedure is finished, it's a small incision, everything's sewn up, and patient is transferred back to the ward. And the beauty of this procedure, and we'll talk about this more later, is really the AF heart team approach with a combination of collaborative working of electrophysiologists and cardiac surgeons. So I'll hand back to Mr. Yap and the team in theatre. John, over to you.
Yep, thank you. Okay, first of all, I'm just going to go through the instruments that we use. In terms of accessing the space, which is the pericardial space to the back of the left atrium, this is what we call the cannula. And within it, we will have a 5 millimeter, or it could be up to 7.5, even 10 millimeter camera. It's just a standard endoscopic camera. And if you can see, if you get the view from the camera, can you switch to the camera view? The incision is just under 2 inches. It varies in terms of the patient's habitus, how big an incision we need to make. So, and this is the EpiSense that Saeed has talked about. And the important thing is that it's water cool, so there's water going in so that it continuously cool it. And the interesting thing is that the cannula itself is connected to a suction and an irrigation cool saline. All this is because in the early part of the experience back in the use of this technique, there has been 1 or 2 important complications of esophageal injury. And since then, the real primary focus has always been to prevent that, and we have fortunately not seen any at all now, even worldwide, by adopting this strict protocol. So now we've got cooling in the cannula, cooling in the device itself, and more importantly, if we can show a picture of the temperature probe, which is a real-time temperature probe, and it is right next to the device. Can you show that, Saeed? And maybe pointing it out with a pointer? Then we can start. Okay? Yep.
That's what you're saying,
12
Dr.
points
Yap?
on it, and it runs all the way down the esophagus. So this stays in place during the ablations, and as soon as there's a temperature rise, John and the team are very meticulous in coming off straight away, because safety again is paramount, as John alluded to. So the temperature probe really makes a big difference. It's positioned at the start of the procedure after the TOE, and once the surgeons are happy, they start accessing the heart.
All right, thank you. So we're going to access the heart now. We saw that small incision. And the nice thing about this procedure for the surgeon is that it's all direct access. And we do not stop anticoagulation for the patient. Now we see the acute margin of the heart already. And that is the pericardial hole that we've made earlier. And now we see an interface there. Beautiful picture there. We can see the interface there. This is where we can progress the cannula. And this is one of the really important features. I think that's the coronary sinus that's coming into view. So the landmark. And what we always do is that we go straight into the back of the left atrium. Okay? And now we are on the back of the left atrium. And if you see that flick that I have done there, because the patient is quite thin, and that's the spine itself. So, you know, we just got to be conscious of that, but that's not an issue. And if you look at that reflection, and see if I can show it, you see that blue line there, and just in front of the blue line is like a fold reflection there. That is the right inferior pulmonary vein. So that's our landmark. So if I flick over the other side, for similar way that the reflection is, that's the left inferior pulmonary vein. So we are actually at the back of the heart. So the orientation is that's the left and that's the right. Okay, that's quite clear. And you cannot see the right superior pulmonary vein. So that's the left atrium in AF. And as we rotate, this is one of the things that we always teach, very important. As we rotate, and as we come up, we see the important structure there, just at the notch there, just at the notch of fat tissue. That's the inferior vena cava. So those are landmarks that we need to know about to make this procedure really safe. And as we come up, if
John, 1 second. Can you just, Simon will just point out the landmarks that you've just talked through, just to make it clear to the audience, if that's okay.
Yeah. Just there, that fold. You see that bluish fold? Yeah. The bluish color, that's the inferior cava. Inferior cava and IVC that you don't really want to push. You never push. And when we rotate that, we turn around, and look, this is the right atrium. We can actually get to the anterior part of the pulmonary vein. So I believe that would be the superior pulmonary, right superior. And if I flick up there, just at the top there, that's the SVC. So it really is quite a nice direct view movement. There are no blind spots that you worry about. And you can see everything. That's the right atrium. You see the blueness? Never push. We rotate back. Boom. We're back into that interface. So we're on safe ground again. So now we can have a look. And that blue thing is the coronary sinus. That's important because Syed tells me that when I ablate, I should not go too close to it because it causes a certain issue with atrial tachycardia. So I'm learning a bit more about EP as well. So we're going to clean the lens and we're going to start ablation now. And it's from now on, it's just, you know, covering the area. And so I go back to a starting point.
And
that's the right pulmonary vein. Yep. And
sorry, I don't know if you can hear me.
So we're going to put our device through and do the first.
Can you hear us in the OR as well?
Yeah, so that's the device, and there's a marker pointing up to show that I have to point it up. So we put it in there, suction on. So we got suction on, irrigation. Okay, and there we go, and kick it. So we start ablating. So this is the tricky bit that we have to do nothing for 90 seconds.
Dr. Yap,
so safety is the really prime concern. Yes?
Can you hear me? This is Julian from Frankfurt. This is amazing
Yes, hi.
views. I am really excited to see this, and I have to admit, from my understanding, it is the orientation requires some training, I guess. There is a question
Yes.
from the audience asking what
Yes.
type of patients would be your ideal candidate. I mean, now you have a redo procedure basically, but apart from that, what are your selection criteria? Maybe this question goes out to the AF Heart team.
Yes. First of all, we do not do this for paroxysmal atrial fibrillation patients because they don't need this procedure. So these are patients that certainly are the long-standing persistent. And there's a heterogeneous group of patients here. And a subgroup that we've been working on are the cardiomyopathy, where getting them into sinus rhythm seems to give them a really new lease of life, certainly for as long as the sinus rhythm is maintained. But because when we started the program, we pretty much took on everybody. But I'm sure Saeed can help and answer that.
Thanks, Julian. Thanks, John. So, I mean, I guess as John said, when we started some years ago, we were starting on patients who no one wanted to do an ablation on in the cath lab. And as time has evolved, we've tried to target the long-standing persistent AF patients, either de novo if they've got cardiomyopathy, or if they've got a particularly dilated left atrium like this lady, or have had previous failed catheter ablations. We've now started our surgical AF MDT together with EPs and the surgeons, and every patient that is referred for this procedure gets discussed and their echo images, their history is reviewed. So we've got an MDT meeting, and so long-standing persistent is the main population of patients we're trying to treat with this procedure.
Okay.
Good. So
maybe I
just
also in the
doing
panel,
it like a mattress.
What patients would you, or have you ever sent a patient for this type of operation, like a Converge idea, following that idea?
But thank you for the question. I mean, it's a nice case. In Brussels, my surgeon is Marc Lamer. We have a huge program of AFib ablation and concomitant, and we do another approach that is with the minimal invasive thoracoscopic, but we know this technology. My question to the case, I mean, I would like to know what you will, how you manage the redo case. I mean, when the pericardium being touched, how you approach the patient, and do you often concomitant do the closure of the appendage in this case? That's my two questions.
Yes, very, very good question. Certainly, we will not do it on anybody who had previous cardiac surgery because we will expect the adhesion to be too much. We have certainly had patients with adhesions following catheter ablation in the past. And 9 times out of 10, you could mobilize the space and deal with that because you can see the view is amazing. So in terms of, what was the other question, the second one?
Concomitant.
It's the closure of
concomitant left atrial appendage clip. Yes. Amazingly that you've asked that question because that's the next thing we're doing. So yes, we feel that is a right thing and good thing. At the moment, you cannot get to the... Yeah, we would hope so, yeah. And but it's finished, suction off, yeah. Yes, that's the program we will definitely do, and we've just got the approval to go ahead and do it. So if I just show you, these are proper real burn in the system, and we move on. Yes, I think the AF team thinks that we all feel that the left atrial appendage is extremely important. That's why we will be addressing it. Yes.
I work also often with the surgeons, and I think the candidate for this procedure, I mean, for what I like to call is a hybrid, when the electrophysiology work together with the surgeon, I find very nice, is the long persistent. I mean, when the catheter doesn't work anymore, I mean, you should think out of the box, I guess. in its state to just provide a normal catheter approach, I think the best candidate are the failure of long persistent that they do not respond on the catheter ablation. That's my kind of patient. And for sure, when they have an indication for closure appendage, I mean, we always, our cutoff is the atrium dilatation. I mean, when you have a dilated atrium, these are the best candidates. I mean, when the atrium is go up more than 60, I think they are the best patient because the closure of the appendage can play a role in the remodeling.
Yes, I think
Richard,
I totally agree. It's certainly not the first line treatment.
what are your
Saeed
thoughts
answer
on the ideal candidate for such a procedure?
Sorry, can you repeat that question again?
Richard, I hope you can hear me now. And I was wondering, Richard, what is your perspective on this hybrid or concomitant or convergent procedure?
Set at 38.
Don't you think that one can also ask, okay, this lady, she had undergone 2 times percutaneous AF ablation, and now we do some empirical lesions, maybe without perfectly knowing what is going on from an EP standpoint? I cannot hear you. I'm not sure if my question got through. So
I think somebody from
Richard can hear us.
Yep. I can hear you.
Flash it. Yep. Okay.
You can hear me now.
Yeah.
Right. Sorry. So I think that the idea of isolating the posterior wall is becoming increasingly popular, and there seems to be some evidence that that has an impact. However, endocardially, I'm really nervous about doing that because I'm terrified of esophageal fistula. We don't have access to esophageal temperature monitoring in the cath lab terribly easily, and even if we did, I'm not convinced that that guarantees you won't have a problem. So I think an experienced surgeon who's pointing the energy forward away from the esophagus and really taking it to that posterior wall is pretty attractive and seems to me a very safe way of dealing with that. And frankly, at the moment, I don't think any of us know what the right thing to do is with these long-standing procedures where it failed with pulmonary vein isolation.
Right, absolutely. But still, on the other hand, we don't know what is the current status, or are we 100% sure that all lesions are permanent and durable?
So that's a good question.
I guess that's true for any lesion.
But the nice thing about this procedure is we've got the epicardial ablations going on, and then the patient comes back, or in some places they do it as a single setting procedure. But here at Barts, we will bring the patient back in 6 weeks or 2 months and do an endocardial ablation, and I'll show you some maps shortly where we can check that transmurality of those epicardial lesions. And it's actually, most of the time, it's pretty impressive. There are some limitations which I'll go through. But yeah, I think these are long-standing, durable lesions.
Yep.
And that's been our experience so far.
Yeah.
Oh, absolutely. If I can add something, can you hear me?
Too much.
Yeah.
Yeah, we published the 2 years follow-up in the case where there was a recurrence of AFib after a hybrid approach.
Yeah, that's fine.
Was a biclamp, the bipolar clamp, but whatever. I mean, these tools are very powerful and are very transmural. So in the redo case, not on the one that didn't recurrence, but the one that we went back with the catheter, actually the lesion done by the surgeon, they were very stable. I mean, the stability of these lesions are quite trustable. Of course, it's not enough to treat AFib. That's another story. I mean, AFib patient is a progressive disease, is a patient that has a journey, and we have to, of course, follow up. But honestly, thanks to the surgeons working together, we were able to bring back the patient on a paroxysmal AFib. and sometimes even control completely with drugs. That for me is success. I mean, when you take somebody with a long persistent with a 60, 65 millimeter, I think if you bring back on the paroxysmal or keep in sinus with drugs, I think it's a success rate. But the stability of the lesion was quite trustable. I mean, these tools are quite powerful, believe me. It's for most of them is like our single shot device. I mean, it's really, and I'm happy that the surgeons are there because they are so powerful that they have to be careful how to manage. I mean, what he's doing, it looks simple in that way, but actually is very carefully keep away the coronary sinus because it's a tricky part of them where you can have many complications. And getting the posterior wall, just looking the inferior vein like his ear, it's not easy. I mean, he has to really follow up, and he has to have a very well knowledge of endoscopy way. I mean, it's not an easy procedure. As a surgeon, they need also training. The learning curve is not so easy, but I think I love to work with the surgeons. I mean, they give you really another vision. But with the stability of a lesion, you don't need to be afraid about that. For the disease himself, to take is enough? I don't think so. But it's for sure a good step for a patient that they will not be candidate anymore for a catheter ablation.
Yeah.
If
I can.
We discussed a very important point.
I know.
Because I think the co-working and the maybe in a subsequent or and having the intervention electrophysiologist on board as well, checking and adding on additional lesion spots if required is an integral part. And I fully agree with what you said.
I think we don't need to leave
if I can come in here.
Because, the surgeons, for interventional cardiologists are daily working. I mean, they are really working together all time. I think if we bring the surgeons together with us, I mean, if you think IFU ablation started by the surgeon, it was not started by electrophysiologists. I think there is a big future and there is a lot of advantage to working together. I always try to push everybody to try to collaborate more and more with the surgeons. I know that everybody here in the panel, they are doing that. But I think it's a big advantage for everybody. If you want to run a full AFib program, I think the surgeon should be there. That's my opinion. I mean,
Professor Spector also has a comment and.
Thank you. So we do, despite what Richard said, we do box lesion sets to isolate the posterior wall at times, which I think in certain patients can be very beneficial. But we only do that if we've mapped and we see that the posterior wall appears to be driving rather than driven by the atrial fibrillation. So we look at the frequency of the posterior wall relative to other parts of the atrium. And if it's going slowly and activating in a somewhat organized way, we feel that the box lesion set is not worthwhile. So my question is, how do you feel about pre-procedural mapping of atrial fibrillation to make a decision about who's likely to benefit from this procedure?
So I think the answer to that question is, from our experience and our belief in this cohort of patients, and I've got a few slides which if we have time I'll run through, is that the posterior wall and the substrates, which is becoming increasingly important in long-standing AF, is our target here. So we will map the patient after this procedure, but this is not like a thoracoscopic surgical AF ablation. This is a single incision procedure where there's no deflation of the lung, and the procedure takes about an hour and a half. So this is a relatively low-risk surgical procedure. And from our experience, as the experience of the team has grown, the procedure can be done safely, and the patient comes back for a post-epicardial ablation mapping in the cath lab. So, bear in mind that a lot of these patients have previously had failed catheter ablation. So, in a way, we know that the candidates who are selected for this are kind of the ones we want to target. Okay, if I may just quickly run through slides, and then we'll go back into theatre and we'll take any questions from the panel or the audience. So can you switch to presentation? Great. So, as we've already discussed and the panel's discussed, you know, as it stands with persistent AF, especially long-standing persistent AF, outcome data is not great. Yes, we all agree paroxysmal AF, we're getting better, the outcomes are good for patients. But this is the long-term follow-up of 1 year, 2 years, and 3 years from various centres and registries. And, you know, these kind of figures, in this day and age, we want to try and do better. We want to try and achieve higher goals. We know the gold standard is an open chest surgical ablation, which has long durability, and the lesions last 36 months. So what is it that we need to do beyond catheter ablation and beyond pulmonary vein isolation? Because we know that from STAR AF2, that pulmonary vein isolation is the same in terms of outcome as doing additional lines or cafes. So we're moving away from that. So coming to the posterior wall, and you can see in this animation, what happens in long-standing persistent AF is that the posterior wall is bounded on either side by the pericardial reflections. And with comorbidities such as hypertension, obesity, diabetes, all these things lead to a progressive stretching of the posterior wall. And as that posterior wall stretches, we know that the scar tissue, i.e. fibrosis, originates. And it's this fibrotic tissue, which again is the substrate for what we're trying to target here on the posterior wall. And these rotors or ganglionic plexi, whichever mechanism that you wish to believe or follow for you know, the etiology of persistent AF, a lot of them are all centered around the posterior wall, and that's why it's become a target. So there's this stretch inflammation, fibrosis and fibrillation hypothesis, which is kind of the crux for which this convergent procedure is based on. As Richard said earlier, we know the catheter ablation doesn't effectively reduce high-stress regions. And in fact, we can create more patchy areas on the back wall leading to atrial tachycardias and arrhythmia. Moreover, the safety of delivering catheter ablation on the posterior wall is something that concerns a lot of people, understandably. This paper published recently did an endo-epi mapping of patients who've undergone posterior wall isolation with catheters in the cath lab. And in a significant number of patients, the epicardial map confirmed that these lesions weren't transmural. And this again highlights and emphasizes the importance of, in a select group of patients, trying to deliver epicardial and endocardial ablation. So the device, as John has discussed earlier, is the EpiSense device. This is a 3mm helical coil unipolar ablation catheter, which sits on the posterior wall and is irrigated continuously. There's a vacuum inside the helical coil which sucks up the posterior atrial wall into the tissue, and energy is directed away from the esophagus. Alongside that, you've got very careful esophageal probe monitoring to see if there's any temperature rise. So it's a safe, effective procedure, and what you can achieve is these overlapping lesions. So the evolution of this procedure started with a curved electrode along a guide wire, and over time the safety of a straight catheter with a vacuum delivering lesions away from the esophagus has proved to be effective. And unlike catheter ablation, where you have single points, these give multiple long lesions which can be overlapped. The surgeons used to use a transdiaphragmatic approach, and again, initially, following initial experience, this had a higher rate of complications. So now we've moved to a subxiphoid approach, which is away from the diaphragm and is a lower risk access. And you can see on this animation, this is the lesion we deliver with a catheter, and this is the length of the lesion that comes from the EpiSense surgical ablation catheter. So as an electrophysiologist coming to theatre, one of the first things I learned, is I had no idea really about the pericardium and how it affects ablation, and especially the pericardial reflections. And what you can see on this animation is the different morphology. So this is important for the surgeons when they're doing the ablation, because it's the pericardial reflections which restrict access to the posterior wall there. And they come in different orientations, if you like, and probably this type of orientation is the most common. So what you can see is there's certain areas epicardially which the surgeons can't reach to address the pulmonary veins. And this is where the endocardial component of the convergent AF ablation comes in. We just go to a quick endocardial map, which basically here is showing a bipolar voltage map after the patients had their surgical ablation and have come back to the cath lab. Obviously red is scar on the posterior wall, and for animation purposes I've set this as 0.2, but actually I use atrial voltage as 0.1 to get even more sensitivity. And you can see that there's healthy tissue on the anterior wall, but there's areas here around the right pulmonary veins where the pericardial reflections limit epicardial access. So with the ablation catheter in the cath lab, we can complete pulmonary vein isolation, and we can target any other areas endocardially that we need to give really a true posterior wall isolation and a complete lesion set. And I'll just show you some endocardial maps following ablation, and you can see the correlation of the pericardial reflections and how it affects the surgical map. So this is a nice case where you've got a good dense area of scar. There's not really much healthy tissue here. So the grey is the scar and purple is healthy tissue. But in other cases, you may have very low pericardial reflection, so the surgical team are limited in how far up the posterior wall they can go with their ablations. And finally, here in grey, you have scar tissue and purple is healthy, and you can see the pericardium here is limiting you to a more narrow band in the middle of the posterior wall. So it's important to be aware of these limitations rather than to swear at the surgeon when the patient comes back to the catheter lab, which I've tried to avoid doing with John. So just very quickly moving on to some data. Initially, when the conversion procedure started, there was a lot of resistance, and understandably so, or reluctance. This was a new technique. We don't want to send as an EP community, we said we don't need to send our patients to surgery for AF. We can treat that ourselves. But we know now that in this group of patients, this is not effective. And the early studies showed mixed results. So, there was a high complication rate. Some of that was because of the transdiaphragmatic approach and the learning curve. But none of this data was overly compelling. It was encouraging, but there was not randomized trial data. We've looked at some of our patients who we've been ablating for the last 6 or 7 years, and we did a retrospective propensity match, which looked at patients who had dilated left atriums, long-standing persistent AF, and we showed an arrhythmia-free survival in the conversion group of 58% at 3 years, as compared to 30% in the catheter-only ablation arm. And these early studies led to demand for a randomized controlled trial, which the results of which were published earlier this year. And I think this has really given us some more impetus to carry on with this procedure. So the Converge IDE trial was a multi-center, multinational randomized controlled trial looking at 153 patients randomized to 2 arms. So half the patients, some patients went to the hybrid convergent arm, and the other group went to the endocardial catheter arm. And this was randomized in a 2-to-1 fashion, patients with persistent and long-standing persistent AF, and they were followed up for 12 months and are having ongoing long-term follow-up. The inclusion and exclusion criteria were age between 18 and 80, symptomatic persistent AF, and atrial size was allowed up to 6 centimeters, and they had to be refractory or intolerant to at least one antiarrhythmic drug. The exclusion criteria you see here, as we would expect, they couldn't be patients who'd had a previous AF ablation or previous cardiac surgery. If their LV was severely impaired, they were excluded, and any history of CVA, pericarditis, or TIA. Also, anything which would suggest that they may have adhesions would be an exclusion criteria. And in terms of the lesion sets that were delivered, in the hybrid convergent arm, the patient would come and have surgery, have posterior wall epicardial lesions, and in the cath lab, they would have completion of the right and left pulmonary vein isolation and a CTI line for atrial empirically performed. The the catheter-only arm would have whackers and a roof line as well as a CTI line, and CFEs were not allowed unless the rhythm did not organise into an atrial tach or sinus rhythm. So really, the endocardial catheter arm had a pretty much free rein. If they were still in AF, you could pretty much do what you like. Again, these were long-standing persistent AF patients with an average duration of AF of 4.5 years, and long-standing persistent comprised a significant proportion of those patients. And the primary effectiveness was freedom from AF at 1 year, and you can see a significant difference in the hybrid convergent arm at 67.7% versus catheter only at 50%. And here you've got, if we look at AF burden reduction, a difference of 80% versus 56.8%, and we understand that this is becoming increasingly important in terms of how we're measuring outcomes following AF-based interventions. The other concern that had previously been raised was primary safety events through the 30 days post-procedure, and the complication rate was 7.8% through 2 procedures. This was mainly driven by cardiac tamponades. There were no atrioesophageal fistulas. There were no deaths. I just want to briefly talk, because it's been raised earlier and it's a good point, and we're certainly very interested and are planning to start this in addition to the Convergent procedure, is the role of the atrial appendage. The BELIEF trial is often quoted as being the study where patients with persistent AF were randomized to a conventional catheter ablation versus catheter ablation plus isolation of the left atrial appendage. And there was a significant improvement in outcomes in patients who had both LAA isolation and standard ablation. However, what we know is that catheter ablation of the left atrial appendage is not an easy feat, and often it's not possible to isolate the appendage safely. What was interesting, and this is data from New York in Felix Yang Center doing the Convergent AF ablation, is a lot of their patients, and we've had the similar experience initially, were coming back with atrial tachycardias after their procedure. And a lot of these tachycardias were originating from around the left atrium, the left inferior pulmonary vein, and mitral isthmus dependent flutters. What we know also is that the ligament of Marshall is gaining increasing interest in the EP community in terms of playing a role in mitral isthmus dependent tachycardias, and alcohol ablation of that is becoming more prevalent. And I just want to play you a quick animation before I hand back to John. So this is a video of the AtriClip, the surgical clip, which is used to occlude the appendage. And what you see here is also, you can very nicely see the ligament of Marshall epicardially. Now, the procedure is thoracoscopic, but when you go in, it's very easy to cauterize that ligament of Marshall directly. That adds about 30 seconds or a minute to the procedure. And then here you see the left atrial appendage very clearly, and here's the AtriClip, which can be delivered quite neatly and repositioned as needed. But what you see is you get a total occlusion of the appendage right at the base. And what's nice about this is not only does it occlude the appendage, but you now also get electrical isolation of the appendage. So you've got appendage exclusion, if you like, there's the terminology for that. And what we see is, sorry, just bear with me. What we see is that atrial appendage endothelializes within 90 days. So it basically absorbs into the epithelium. And if you do a TOE in these patients in 3 months, you won't be able to see an atrial appendage. So basically, before we hand back to John, this Converge IDE trial that I've presented is the first randomized clinical trial, which clearly shows superiority of the Convergent hybrid AF ablation versus catheter-only ablation in persistent and long-standing persistent AF. We've demonstrated an acceptable safety profile, and with increasing experience in centres across the world, this has now become a safe procedure to offer patients. it emphasizes the value, as we've discussed, of a real team-based approach. And certainly it's been a pleasure for me to collaborate with John and the surgical team, and likewise, hopefully for him. But we've both learned off each other in terms of how we do this procedure safely. And again, addition of the LAA occlusion as part of the Convergent procedure is an exciting addition which may lead to improved outcomes for patients. But what I really wanted to end with was just to say that I think we're in a new era of AF ablation now, and we've got tools and techniques such as the Convergent procedure, which we can potentially offer patients to deliver better outcomes. And I think trying to do catheter ablation in certain groups of patients is no longer acceptable given the limited outcomes we have in these patients. Thank you.
Okay.
Perfect.
Yeah.
Thank you very much.
We've done 14 lesions now. I'll show you when we're done this one. There was a question about the TT maze or the thoracoscopic technique. That's a really good technique as well. It's just that the learning curve for that is a little bit more challenging. In terms of the Convergent procedure, if your surgeon has done TT maze, literally they will be able to do this after really one or two proctor sessions. But with people that have not done it, and we've taken through people now in the UK and Europe, the learning curve is actually quite very palatable. And there's no blind spot to push, so you can see everything. And as I mentioned, if you know where the landmarks are, we've learned from our predecessor that have paved the way. Things like IVC injury should never really happen because you see it. In the past, that was a bit more challenging, especially through what we call the transdiaphragmatic suction off approach. But now it's all subsifoid, and really that has really transformed the safety aspect of the technique. These are the lesion set, yeah. See, they are real proper ablation, and even that look, I've already done nearly 2 rows. Yeah, as I come up here, let's strip that out. Just clean that, dry that, and as I say, in terms of safety, and safety is always my prime concern. We see the ablation. And then there's the inferior pulmonary vein where you see the fold, where the notch is. And then I come back up, and you should always see it there. That's the IVC. So that used to be a real problem as an injury-prone structure. But now that you see it, it's okay. That's the IVC. And we always learn for surgeons that are training that there's a interface. Like, for example, if I'm like this, I would not push. If I'm like this, I would not push. But I can see the interface. So there's a road there. So I just roll. There's an interface. I can go in there. So there's actually a map that you can just go through. And we're pretty much quite high up now. So those were ablated. And sometimes it chars a bit more. Sometimes it tend not to. So because it's all by visual at the moment, we have to really, if I'm not sure about that bed, so in go the device, suction on.
John, can you just tell us how you get the overlapping lesions on the posterior wall?
Yeah, that's what I'm doing there. Suction on. There you go.
If I can ask you, can you hear me?
Suction. Yeah.
How often, this is amazing and it's fascinating what you do and looking into the beating heart. How often do you observe termination during ablation at the posterior wall, for instance?
Yes, not as common as I hope. Probably out of the 100, just under 100 that we've done, we've seen about 4 or 5 only.
Okay, all right.
So, yeah. So the trigger point might be somewhere else. But my main primary job is to use the word debulk the posterior wall.
Right, right.
So just to finish off in terms of surgeons learning it, it's certainly a much straightforward procedure to learn. Compared to the thoracoscopic. Yeah.
I think you prepared, Paul, a question for the audience, and I would like to to move on with that question, and maybe you want to ask that question yourself.
Yeah, sure. Yeah. What is the average length of stay for this procedure? That would be the question. How long do the patients stay for, on average?
And the potential answers are 2 days, 3 days, 4 days, or 5 days. Yeah. And we can vote now. What is we would guess?
Yeah, because we know the TT maze have got a slightly, quite an interesting varied length of stay. Okay, suction off. Yeah. Okay, and if anybody wants to see anything else, we're continuing to ablate, just let me know, like structures or anything. Like that's the coronary sinus again. Again, everything is right in front of you. Just clean the camera. And, that's the coronary sinus. Yeah, so we push down.
So the other thing to say is that we have done some cases in the hybrid theatre that we have here as a single setting procedure. So after John's finished doing the epicardial ablation, we do the endocardial map. Now there's advantages and disadvantages to doing that. For the patient, it's a nicer experience because it's a single procedure. The patient comes in, has both endoepicardial ablation and goes home the same or after their one stay. The slight disadvantages are that you do generate some edema, perhaps from the epicardial ablation. So evaluating the true nature of the scar in the endocardium can be slightly more challenging and maybe less accurate. So that's the advantage of doing a staged procedure. So that's one other thing. And the other thing I wanted to say is that there is the facility to do epicardial mapping through the, epicardial sensing through the Episense ablation catheter in theatre. So if you've got a particularly keen surgeon who likes looking at electrograms, like John, then it's also a useful tool to monitor the epicardial ablation.
Yeah.
Right. I think we have the results coming in from the poll, and the poll was the question, as was how long do the patients normally stay in hospital, and 5% did guess 5 days, 3% voted for 4 days, 34% voted for 3 days, and the majority, and the absolute majority, 57% was probably the correct answer for 2 days. So it's almost like an percutaneous catheter ablation procedure, I have to admit.
And this is the nice thing, and this is what we're trying to express to cardiologists who may not have seen this before, is that the perception of cardiac surgery is that the patient's undergoing a major operation, they're going to ITU, they're in hospital for weeks. But actually, you've seen this is a minimally invasive surgical procedure. The patient goes straight from here to the ward. We used to put them through HDU and ITU, but they can go straight from here to the ward. Some patients may get a bit of chest pain afterwards, which is a bit of pericarditis, and that can often be managed effectively if needed with non-steroidals and colchicine, particularly if they're having a single setting procedure where everything's done at the same time. But really, I mean, you can see that this is a comprehensive posterior wall ablation, which is minimally invasive.
Exceptional.
Yeah.
And
Peter,
2 days is absolutely right.
Peter, if I may ask you, I mean, according to the randomized data, which have been presented also this year at HRS, what is your view on this? Do you think it is rather a conceptual trial looking into the role of the posterior wall, and maybe even we as an electrophysiologist may come up at a certain point in time with other weapons maybe and go for a similar efficient ablation, or is it surgical access specific approach and also related to then the success rate due to the surgery?
Thanks for the question. My personal opinion is that our choice of ablation, whether it's surgical or transcatheter, currently is very much limited by our ability to identify the mechanisms of fibrillation in individual patients. So I think that when we get to the stage that we're able to create more reliable maps that give us a sense of not only which regions of the atrium are driving fibrillation in an individual patient, but which mechanisms are at play in those regions. For example, I believe the treatment for multiwave reentry is different from the treatment for focal rotor or structural micro reentry driving fib. So I think when we have the ability for guided procedures, our goal should be to be as efficient as possible. And by efficiency, I mean not simply quantifying how effective our treatment is, but getting greedy and trying to quantify how efficient it is, how much anti-fibrillatory effect we can get with how little ablation. And my hope is that over time, with more and more information, we'll be able to deliver smaller and smaller lesion sets for the same effect and leave behind an atrium that is ever more functional.
Okay, kick it.
Very good point.
The patients go recover and go straight back to
Richard,
the ward.
I think you also have a comment.
Yeah.
I wanted to ask John a question, if he can hear me.
Mm-hmm. Yes.
So John, I'd imagine that most of your patients don't have a six-pack the way that Said's slide suggested they did. Does weight and obesity make a difference to the procedure, and do you deselect patients if they're grossly obese?
No. In fact, when we speak to our American colleagues, they have a fair percentage of patients that had quite high BMI, and we have the same experience where it's accessible because it's minimally invasive. So we don't make too much destruction, and it's fine.
I think, Richard, I think you make a very good point, though, and a lot of these patients are obese, have poorly controlled hypertension, have got obstructive sleep apnea. And I think, again, one of the nice things about working in collaboration is that, we are trying more and more to address those risk factors, not only prior to surgery, but also ongoing and afterwards, because we know, as with any other catheter ablation for AF, that if those risk factors can be adequately controlled or improved, the patient will have better outcomes. And I don't think there's any difference with this hybrid procedure.
Maybe there. Yeah. Are we back on? Yeah. Just to show you that we are really starting to achieve uniformity here. There, going around. This is that reflection there. If I just point towards there, is the right inferior pulmonary vein, and we've got ablation right around there. Look, yeah. So that little bit I've ablated before. When there's a bit of fat, it may not show up as obvious, but I'm going to ablate again because this is all visual, so it'll be easy enough. And that reflection is the left inferior pulmonary vein. So we are nearly there. So, okay.
Since we are approaching slowly the end of our very interesting session, I would like to ask you, what is the end point of your procedure?
Very good question. Again, at the moment, we don't have the facility to test it or map it. Although there's a rudimentary technique within the device that can kind of indicate it. So it's all by visual. I visually feel that I've completed the lattice of covering the area. And we won't have time today, but I can actually do the anterior pulmonary vein as well on the right side, and possibly towards the part of the superior. This comes with experience, but Said tells me I actually don't really need to do that. because he can pick it up on EP catheter, which is what makes this procedure really quite nice. And just quickly, this has done is that it's really expanded our cooperation. And now we've got EP doctors looking at our concomitant. And we actually started a AF MDT as well. So this is really growing into a very positive outcome.
All right. Thank you very much. So
thank you.
Then I am afraid that we are moving towards the end of this session. I want to really thank you and the team in the OR. I want to thank Dr. Saeed Hassan to present also the AF heart team from the EP side. I also want to thank, of course, the panel, Richard Schilling, Peter Spector, and we lost Carlos Asmundis, apparently electrophysiologist. We don't have this standing. We cannot stay that long in the OR. Thank you very much, everybody. And we are moving on within the program to our next session. It's going to be a back-to-back session, also with a live case, and this will be presented, I think, from Leipzig, Germany. Thank you very much again, and see you soon. Stay safe.